Simran Kafle.
Honorable Chair, Co-Chair, respected audience, a very good morning to everyone. I'm Simran. I'm a PhD candidate at Department of Public Health, Nhrc University, and I'm glad to present one of my research papers entitled Does Nepal's National Health Insurance Program Protect Against Catastrophic Health Spending? So these are authors, and most of them are my supervisors with an expertise of economics and public health. My whole research paper has a base in this slide where, thank you, where I want to show that out of total health expenditures, 54% are paid out of pocket in Nepal. And this is one of the major challenges to achieve universal health coverage, not only in Nepal, but in most of the South Asian countries. And today, I'm talking about catastrophic health expenditure. It's very critical in our country because when households have to spend considerable amount of money on healthcare expenses, they have to compromise their spending on basic commodities like housing, shelter. To address this situation, Government of Nepal has launched National Health Insurance Program in 2016 so that they can protect their citizens from extreme health expenditures. So this study aims to evaluate whether our government has been able to protect their citizens against catastrophic health expenditure. We conducted this study in Pokhara metropolitan city, employing an analytical cross-sectional design with a sample size of 1276, with a two-stage random sampling. Data was collected face-to-face interviews, and it was conducted in 2023 and 24. So for the calculation of income data, we did it through household spending as a proxy indicator. And for the calculation of household total consumption, we estimated it summing food and non-food consumption, and non-food consumption included healthcare expenditures for the past month. And out-of-pocket related to acute conditions over the past 30 days and chronic conditions or NCDs over the past 12 months were converted into monthly figures, and we aggregated. And healthcare expenditure was based on the self-reported data. It was validated by pertinent documents based on test, treatment, medications. And I just wanted to show some of the bills, how we collected the data. And how did we measure catastrophic health expenditure? It was using the threshold of 10% or more than 10% of total household consumption. And households with the enrollment insurance card was the key independent variable, and household health conditions, socio-demographic characteristics, economic indicators were used as observed confounders. So one of the major features of this research is the use of propensity score matching. Why we used that, I'll be talking about it a bit later, but households were matched one-to-one using the nearest neighbor algorithm, and it was based on the propensity scores with a caliper of 0.1. The objective was to ensure close matches, and it resulted in 534 enrolled households to match with 534 non-enrolled households. With that, the enrolled households become 42%. So the propensity score estimates the probability of NHIP enrollment based on household characteristics. It helps to reduce selection bias in observational studies by balancing the differences in baseline characteristics among enrolled and non-enrolled households. A strict tolerance of propensity score matching was imposed to enhance the precision and to ensure high quality matching. And the average treatment effect on the treated was estimated to quantify the effect of insurance effect on CHE. So for the diagnostic test comparison, we did the standardized differences, and variance ratios were calculated. So these are the diagnostic tools, how we ensure the comparability among enrolled and non-enrolled households. So I will not be explaining much on this part, but what about unobserved confounders? The result might be subjected to other hidden bias. So we did Rosenbaum-bound sensitivity analysis to ensure that our findings doesn't get sensitive to other hidden bias. And we tested gamma values and the t-hat. So what are the major findings? Who are getting enrolled? Households with NCDs, households with acute illness, households with elderly members in their family, households with under 5 children. Those who are in more need of health care are getting enrolled in our program. And the interesting finding is that households who are in the poorest wealth quintile, they are least who are enrolled in the program. And this has been depicted through the statistical analysis as well. And this was the reason why we used propensity score matching to address these adverse selection effect. So another table talks about average treatment effect on the treated. This analysis indicated that 3.1 percentage point increase in the likelihood of experiencing CHE among enrolled households. So in total, 9.8% of households experienced catastrophic health expenditure in the last year. And it's very interesting to note that 4% of enrolled households suffer from CHE even though their health expenses were below 100,000 rupees. And I just wanted to share that this sensitivity analysis, we also showed that the p-value was very negligible, so our findings is not subjective to other hidden bias. So this talks about the experiences of enrolled households. And they shared that they couldn't renew the insurance card this year because we can see that it was 16% dropout. And the major challenges faced by them was long waited time and no availability of medicines. And during the data validation, we also, I'm sorry. And during the data validation, we found that not all the prescribed medicines are in generic terms. That means even if the medicine is available at the health facility, but if we do not prescribe generic medicines, they will not get the medicines at the health facility and they are forced to visit private health sectors, one of the major determinant for high out-of-pocket expenditure. Well, and the most expenditures are on medicines and transportation. I would like to highlight that the very basic medicine, for example, insulin are not included in the insurance program. Ambulance, referral transport are not included in the insurance program, and this is one of the major driving forces for CHE. So I would like to conclude this presentation that our National Health Insurance Program provides very limited effectiveness against catastrophic health expenditure. And long waiting times, it could be solved with a digital online appointment system, and the medical shortages, it could be shortages, the real shortages, or could be some other reasons, it should be further digging out. And the benefit package was found to be very insufficient. As I already mentioned, even the diagnostic PET scan machine is, PET scan diagnostics is not included, chemotherapies are not included. And the findings highlight the need for insurance program to expand its coverage, introduce flexible coverage limits based on the income, so that poor also get into the enrollment program and based on the healthcare needs. If a person is suffering from cancer and if he has that limit of 100,000, he will die. And the state should take responsibility of this. And I strongly recommend from my findings that government should make strategies to mitigate adverse selection and create a balanced risk pool so that it also provides financial sustainability to the program. So with this, I would like to conclude my sessions. Thank you so much. I'm so sorry for taking longer time.
And the policymakers should listen very carefully and translating this evidence to the reality. And what you clearly highlighted, the major contributors of catastrophic expenditure is medicine. Looking at the drugs list, essential drug list, and I was shocked yesterday's presentation, only 0.2% health facility at the periphery level have readiness of providing basic healthcare services. That means there is a problem in terms of supplies, readiness, various things. Why? Are they writing more than what the patient should consume? Or these drugs are not available in a public facility? That's why they go to the private sector? Or why it is? What needs to be changed in order to address this gap? That's my question. The questions are, I'll encourage you to very sweet and short response.
Thank you so much for the wonderful question. I have investigated this issue in detail, though it was not directly related or under the objective of my PhD thesis. But that was really the worrying issue. And I also work as a public health administrator under Nhrc province, under Ministry of Health. So why 98 types of medicines are not available, or why not medicines under the insurance program are available? There are 4 major factors, and I would like to highlight that. The Public Procurement Act and Regulation, which takes at least 6 months to procure basic medicines to ensure its round-the-year availability. How can we make that? The medicines should be procured in a short duration of time, ensuring its quality. And I also want to focus ensuring its quality, because we do not have mechanism to ensure the quality of medicines which we procure on mandatory basis. Maybe people do not trust on our medicines, and they are forced to visit other health facilities whom they trust more. Another is, all the medicines are not under the responsibility of local government. Federal government, provincial government, and local government have different responsibilities to purchase different types of medicines. How will this work? How these 3 tiers of government will coordinate together to buy medicines on what month, how much? This is also one of the major challenges. Another term is that this could be the point of departure for other researchers. What is the demand side and supply side moral hazard? Supply side moral hazard could be that they do not prescribe the medicines in generic terms, and patients will go for branded medicines and they will not find it at the health facility. Another is, what is the demand side hazard? They want medicines for all the conditions. And do we really need it? We have to research on this, and this could be the point of departure for other researchers. Thank you.
Thank you, Simon. There's quite a lot food for thought and future research as well. And this is a beauty of health policy and system research, I must say.